Hello everyone, this is Dr. Vinay from Sun Pharma Medical Affairs welcoming you all this evening to this live webinar on management of diabetes-related complications post-COVID. Before we go through the main agenda, I would like to give you a brief about our doctor outreach program called Sankar. Through this program, we have initiated this followings like enhancing your clinical practice, provide patient management tools, and live webinars for your academic platforms. So this evening program is as follows. This welcome address will be from Sun Pharma Medical, and with this we'll be having live web presentation from management of diabetes-related complications with our honorable speaker, Dr. Suhas Erande. And later on, after the presentation, we'll have a question and answer session. With this, I'd like to introduce our speaker, honorable speaker, Sir Dr. Suhas Erande. Sir has an MD from Medical University of Pune and diploma in Diabetes Care University of Newcastle, Australia. Sir has been practicing consultant diabetologist since last 34 years in Pune and is presently associated with Hospital and Insulin Center Pune. Sir is also a research fellow in ICMR in DI, CID, Jericon, like national platforms. And Sir has been a member of advisory board for Journal of Association of Physicians of India. Sir has written various chapters in Medicines Update, like API textbook for last 4 years, and has been for 6 international published references and counting. Sir has also been coveted with this Diabetes Mitra Award for his social work in diabetes awareness in Pune. With this, I hand over the session to our honorable speaker, Dr. Suhas Erande. Sir, over to you.
Very good evening, friends. This is Dr. Erande from Pune. I'm a diabetologist, as you have already been introduced about. And first up, I express my sincere thanks to Sun Pharma for arranging this academic platform. And I welcome all my friends who are participating today. We are going to touch upon a very interesting and a very relevant subject of diabetes complications management, specifically when they are post-COVID. Now let us go through the details one by one. This is a very obvious fact which I have been observing, and I will repeatedly try to show you evidences to the same, which is if a diabetic is well controlled, that means that the upper limit of blood sugar less than 10 millimole, which is 180 milligram percent, then the survival is practically 98.9%. So it's a fair survival compared to as good as, let's say, non-diabetics. But if the diabetes control is not optimum, that is upper limit is of the average glucose more than 180, then the death rate attributable to COVID infection rises to 11%. And both these problems, both diabetes, now as per the December 2021 International Diabetes Federation Atlas, the number of diabetics in the world has exceeded now 54 crores, 54.3 to be specific. And in India, we fear that we already have crossed the 7.7 crore of IDF 2019. We fear that it has probably crossed 8 crores. So this is one problem on our hand. And on the other hand, we have this new pandemic since December 19, raging through 2020 and especially 2021, which is COVID-19, a new global crisis. And in India, total 4.31 crore people are already infected with COVID-19. We also appreciate a huge number of people who have succumbed to COVID, and quite a lot of them are diabetic. So this is a double whammy. It has been historically seen that the brothers and sisters of our SARS corona or SARS COVID-19 coronavirus, which were coming over the last 2 decades in different forms. So they were in the SARS category only, the severe acute respiratory syndrome category. But it was actually not as bad or as severe as the present coronavirus pandemic. Plasma glucose levels and diabetes were independent predictors for mortality in these previous SARS or MERS syndromes, which were seen in 2002, 2009, etc. The important point there was these were coronaviruses, but probably their virulence was less. And as you can see here, the survival, which is on the y-axis, we have seen that if the plasma glucose, fasting plasma glucose is fair or low, the survival was better. If it was mildly raised, the survival was compromised. And if fasting plasma glucose was high, survival was the most compromised. Another important thing, apart from the corona pandemic, the world faces a lot of crises. What in the form of the environmental problems and different kinds of storms and gales, all these coming up. So, and these days, you know very well that these storms are labeled in different form. For example, Katrina or Kobe, etc. And just see, these are the number of days that the adversity or that storm or that environmental crisis or for that matter Gulf War that stayed to trouble with the world. So number of days, Katrina 8, Kobe 8, Gulf War persisted or it lasted for 60 days, etc. And the tsunami, which was 2004, and we are aware that this was another, you can say, severe environmental adversity the world and lots of Asian countries faced. So this was the effect on HbA1c. As diabetologists, you know, we look at the world from a very precise point of view, which is glycemia, fasting plasma glucose, postprandial glucose, HbA1c. So HbA1c, after these disasters, generally that has gone up 7.65 to 7.6, 7.44 to 7.64. Gulf War, 10.1 baseline HbA1c went up to 10.9. Even in the tsunami, 5.9, which was a fair HbA1c that touched the diagnostic threshold of diabetes. So there was a A1C increment all through different kinds of crises. And how can you imagine that the coronavirus pandemic can be an exception? It is bound to be that way only. Now, my friend, Dr. Avdesh Kumar Singh has already published excellent papers in diabetes and metabolic syndrome, clinical research and reviews a couple of years ago. And he has actually beautifully shown here that the prevalence of severe versus non-severe COVID-19 infections in people with diabetes. You can see here different researchers and they have observed their own observations and they have published it. So non-severe infections versus severe infections. These are the diabetic people. So as you can see here, whatever part of the world, whatever different observation, the common thread here is the severity of COVID infection. Okay. Severity of COVID infection was far more in diabetic people than maybe a non-severe COVID infection. Most of these were Chinese observations in the initial period, and this was the CDC, which was Atlanta, USA. Another important thing, some of our own endocrinologists from India, they had done excellent exercise of estimation of effects of nationwide lockdown, which was the March, April, May, June 2020. And this was for containing the coronavirus infection on worsening of HbA1c and increase in the diabetes-related complications, which is our topic of interest today. And this was, of course, a simulation model. And you can see here that compared to the baseline A1C, the post-disaster A1C was projected to be 8.9 going up to 11.16. If the number of days of lockdown was projected as 30, but if the number of days of lockdown was 3 months, 90 days, then the baseline A1C of 8.9 could easily go to astounding 16.84. Mind you, this is just a simulation model, but we have to take hints from that. and look at the complications. Non-proliferative diabetic retinopathy, proliferative diabetic retinopathy, the need of photocoagulation for retinopathy, the kidney issues, albuminuria, macroalbuminuria, diabetic peripheral neuropathy, need of amputations, either toes or leg, myocardial infarction, and cerebrovascular accident. And you can look at even the last point, which was different other infections also. And you can easily appreciate that if the number of days of lockdown were more, then not only glycemia, the HbA1c, but the complications of diabetes also were projected to go up significantly. And why was this happening? This is something which is very well known now. The SARS-CoV-2 virus entering the respiratory tract, and then the virus invading the alveolar cells, the pneumocytes, and even the WBCs, the immune defenses were altered. There was a lot of secretion of wrong interferons and a lot of cytokines, interleukins, etc. And then the immune defenses were getting altered. The virus was not only restricting itself to the pneumocytes, which is the lungs, but it was actually not only giving pneumonia, but it was attacking different cells of the body through what was called as the angiotensin receptor, angiotensin converting enzyme 2 receptor. And this was affecting the endothelium, it was affecting the heart, kidney, lot of other organs, even intestines, etc. And that's why we were saying not only lung infections or ARDS, but systemic inflammation and multi-organ dysfunction, the endothelium, the blood vessels getting afflicted as a common thread in most of them. Diabetic microvascular disease increases the risk of severe COVID-19 infection. Why? Because there are a lot of, you can say, common threads there. Diabetes with microvascular complications, existing systemic endothelial and microvascular dysfunction, which is known feature of diabetes. COVID-19, acute microcirculatory impairment and additional endothelial and microvascular dysfunction. So the summation of that doesn't remain a sum, but it becomes multiplication. So excessive pulmonary endothelial and microvascular injury, cytokine storm, and more severe COVID-19 outcomes. Endothelial dysfunction, which is a baseline tenet of microvascular impairment, can result into multi-organ damage, like for example, retinopathy, nephropathy, and coronary artery disease or cerebrovascular disease. This is, you can say, a bit complex. Some, you can say, exhibits from my side, a bit complex, but they are very important for understanding. This is microvascular dysfunction in COVID-19, the MYSTIC study. This is the healthy specimen, and this is the COVID-19 infected specimen. What is the specimen showing us? This is actually the endothelium, the last one. In between is the glycocalyx, the intervening space, and again the glycocalyx. What is actually the feature here is these are the different receptors, ACE2 receptor or the ANGPT, etc., which are there on the endothelium. And COVID, through different messengers or through different cytokines and inflammatory substances, what is it causing? There is a ACE2 mediated, thrombomodulatin mediated, hyaluronic acid mediated, or even ANGPT2 mediated endothelial injury. Then there is another important thing which is simpler to understand. The transit time of blood circulation or the perfusion through the capillary circuit or the microcirculation, that is altered. In fact, that is delayed. The RBC velocity, the capillary density, the glycocalyx thickness, all of these adversely affected. So the capillary transit time delayed, and there is a subtle amount of generation of hypoxia, which can be in different organs. And the well-known interleukin-6, TNF-alpha, the CRP, ferritin levels, which were investigated also in COVID patients, they were seen to be more. So this was the root of problem, endothelitis, which was very important at the root of various diabetes complications, COVID, during COVID, even post-COVID. And what was the instruction, challenges and recommendations for diabetes management during humanitarian crisis? Very important to understand here that there are some short-term instructions to prioritize type 1 patients who can't live without insulin. In the long term, supply them with insulin, supply them with anti-diabetic drugs, with lockdowns or without lockdowns. Ask them to do the lifestyles as you can say correctly as possible. So good diet, good physical exercise, routine glycemic monitoring, and trying to be in touch with their diabetologists for good diabetes control. And these were the lessons driven out of the Syrian crisis. And this is just a case study. Now coming to the complications and the diabetic the COVID outcomes interface. This is the impact of renal function on admission in COVID infections. You could look at the different scenarios here. If the eGFR is very well preserved, then the survival of these patients is fair, even though they get hospitalized because of COVID infection. If the eGFR is less than 60, then the survival is actually compromised. And if the eGFR is still less, then less than 30, so to say, then the red line, it's the worst, you can say, outcome. The in-hospital likelihood of death is very high. So worse the kidney function, more is the likelihood of death. That was what was seen. And this is something which is again very close to what we are talking today. Assessment of acute kidney injury and longitudinal kidney function after hospital discharge among patients with COVID or without COVID. Look at this. This is the baseline creatinine. The blue is negative COVID and the yellow is those patients who had a seropositive COVID. Maximum, look at this. This is the serum creatinine which has gone up, and naturally it has gone up more in the COVID patients. And down the line, if you see, then the COVID patients continue even 3 to 6 months down the line of infection. Post-COVID, the creatinine still remains high. So this is just you can say one of the proofs that even in the post-COVID period, the organs certainly are not recovered in quite a few cases to their normal health. And this is something which has been, you can say, read out. This is a study of more than 1,200 patients who were admitted because of COVID, and their eGFR was compromised, documented and compromised at the time of admission. And this is from Rhode Island. This study was read out in the last week's American Association of Clinical Endocrinology meeting. So something which is a very, very hot out of the oven data. Adverse outcomes, odds for adults with type 2 diabetes and CKD hospitalized with COVID-19. And what is the, you can say, observation here? If the CKD stage is 5, the odds ratio, that is the risk of the person dying from COVID, was practically 4.67 times. If there was a hyperglycemia on admission, the odds ratio of adverse outcomes was 10.49 times higher. And if the patient was admitted during the first wave, which was a period between March 2020 to September 2020, the odds ratios of adverse outcomes were 2.22 times higher. Also looking at diabetic neuropathy, proportion of patients with diabetes and severe COVID-19 and their likelihood of post-COVID development of severe form of peripheral neuropathy was something which was already commented on as a higher risk, characterized by neuropathic symptoms and small and large fiber dysfunction in feet and face with a loss of smell. So this is something, and loss of smell was very, you can say, popularly discussed in those days. So that also was something of a, some people said that it is because of some kind of a cerebellar dysfunction. Some people said it was something related to the brainstem. Some people said that it is a wider affection of the nerves. So this was already seen in the COVID days, or I would say during actually the active hot COVID wave days. This is again something which is a bit complex. I will tell you the essence of what this slide actually shows. This slide actually is a specimen of the pancreas, especially the human islets and the beta cells. If the beta cell, because of what is called as a neurolipin on the membrane of the beta cell, they are more likely to get affected by the SARS-CoV-2 virus directly. Of course, the ACE2 is another way by which the coronavirus can enter the beta cell. The coronavirus can damage the beta cells. These are the proofs taken from the autopsy specimens of those patients who were dying because of COVID. And it was also observed that if the virus can really do what is called as a trans differentiation of beta cell, then beta cell was just for the namesake. Actually, it was not secreting insulin, but it was really secreting more amount of glucagon. So these are some very interesting observations, and these could be probably the real pathophysiological or molecular basis of what is called as a post-COVID complications. So this is that easier, you can say easier on the eyes and easier on the understanding diagram. This is of course the SARS-CoV. This is the subject with diabetes who is getting infected. Diabetes getting worsened because of hypertension, cardiovascular disease, CKD, obesity. Diabetes itself is inflammatory state, and this is addition of corona to that inflammatory state, hypercoagulable state. And then the demographic features like maybe the older age, male sex was typically, you can say, more at risk of developing diabetes and COVID complications, non-white ethnicity, low socioeconomic status. So these were actually culminating into more problems. So virus was supposedly, as I just now told you, directly affecting the beta cell secretory capacity, the inflammatome or the let's say, storm of the interleukins and other inflammatory substances. The cytokine storm is one of the important contributors of insulin resistance at the skeletal myocyte level, adipocyte level, and at the hepatocyte level. So poor insulin secretion, increased insulin resistance, severe COVID-19 in known diabetics. So people were desperate. As you can see here, this is one of the, you can say, prayers, so to say. And this is a symbol of a goddess of health. And this was a prayer to the goddess of health. And this poster was put on the Tokyo railway station in those days for mass health security. So naturally, people were desperate. This is fairly recent to what we are talking today. Just pay attention to three different investigations. This is continuous glucose monitoring, the first column. The second is insulin levels. And the third is the other secretome, which is inflammatory substances, interleukins, TNF alpha, etc. Different types of people. These are the controls where everything is normal. Okay, the CGM is normal, insulin levels are optimum, and there are hardly any inflammatory substances. Acute COVID infection. You can see here, there is a perturbation of the continuous glucose monitoring post-breakfast, post-lunch, post-dinner. The sugars were tending to be high, insulin levels less, inflammatory substances going up. Post-COVID, our interest today. Look at this. The glycemic parameters are actually worse. Post-breakfast, post-lunch, post-dinner, there are fewer peaks. So people are getting into that dysglycemic phase. Insulin levels certainly fair compared to what it was in the acute phase, but they are not as good as in the normal state or in the physiological state. And the inflammatory substances are going up. This is type 2 diabetes. This is a known type 2 diabetic person, as against these which were not known diabetics prior to COVID. And naturally, you know very well that the type 2 diabetics are bound to have glycemic excursions throughout the day. They are going to have fairly low levels of insulin, and they are going to be having higher levels of inflammatory substances. So it is very important to appreciate here that on the metabolic front, from those people who were non-diabetic prior to COVID, they had some disturbances during COVID infection. They continued to have some disturbances of glycemia even post-COVID. And another very important observation, this is acute COVID and this is post-COVID. You can see it here. And these are the different glycemic alterations. Okay, so some amount of these are the known diabetics. The gray column, the light gray column is those who are not known diabetic but having high sugar, and these are normoglycemic people. What has happened post-COVID? Certainly the number of normoglycemic people has gone up, but still the people who have hyperglycemia, mind you, they are not known diabetic yet, but hyperglycemia still is persistent in the post-COVID phase, and naturally worse, higher the level of glycemia rather than normal to hyper to non-diabetic, the need of oxygen or the need of ventilator, the need of intensive care unit support, all these were found to be higher. Now, during our discussion, there are some points which are, you can say, very interesting. I will try to shorten the discussion here. Are there any differences in the risk to serious COVID-19 infection or death in type 1 or type 2 diabetic patient. Is there any difference between type 1 and type 2? Well, it was observed that type 1s were faring fairly, you can say, worse compared to type 2s in at least one study. Is pre-diabetes a risk factor for serious COVID-19 infection or death? Why are children at lower risk, at least in initial phases? That was the observation. Gestational diabetes, does it really amount to serious COVID outcomes? Why are some races more at risk rather than some others? Does pre-existing tissue damage from diabetes complication predispose to acute COVID-19 induced organ damage and overall poorer outcomes? So a lot of questions are there. And do diabetic 19 survivors face a higher chance of long-term sequelae? So my friend, this is one of the very important slides. And here I have shown that on one hand, COVID is an acute cytokine storm inflammatory response, acute tissue damage, the acute cardiac, acute kidney, acute lung damage, even acute neurological damage. And in the hyperglycemic surges we have, which I have just now shown you, hypercoagulability, higher levels of inflammatory markers, endothelial dysfunction, and fibrosis, lungs, and a lot of other organs. Diabetes, it's a chronic low-grade inflammatory response, higher insulin resistance, slowly progressive tissue damage, cardiovascular disease, etc., glucose variability, hypercoagulability, endothelial dysfunction, fibrosis. So a lot of the ways by which these two, COVID acutely and diabetes chronically, damages the body systems. A lot of the pathways are absolutely, you can say, same. So coming again to post-COVID syndrome, these are the durations, week 1, week 2, week 3, week 4, etc. And the post-COVID symptoms can be varied. It can be fatigue, decrease in quality of life, muscular weakness, joint pains, cough, breathlessness, need of persistent oxygen supply, anxiety, depression, sleep disturbances, post-traumatic stress disease, cognitive disturbances or brain fog, headaches, palpitations, thromboembolisms, CKD, hair loss, so on and so forth. And looking specifically at the endocrine issues, we have already looking into type 2 diabetes and type 1 diabetes to some extent, but there are some thyroid afflictions also, especially in the post-COVID era. This is a WHO definition of what is called as post-COVID, and this is why the Delphi consensus, and we will see the details just down the line. This is our own government, Ministry of Health and Family Welfare, GOI, and they have defined this as something which is very clear: acute COVID signs and symptoms up to 4 weeks, long COVID. These are the ongoing symptomatic COVIDs, or post-COVID is something which has signs and symptoms that develop during or after a known COVID infection, but they continue for more than 12 weeks, that is more than 3 months, and they are not explained by any other or alternative diagnosis. Why are some people more likely to have long COVID or post-COVID sequelae? Well, type 2 diabetes is of course the first culprit here, but there are some other markers like maybe Epstein-Barr virus found in the blood of these patients and some autoantibodies also found in these patients, and they were more likely to have prolonged or maybe post-corona acute sequelae or post-corona syndrome. And what was observed by Professor K.M. Venkat Narayan from the Emory University, US, he has seen that glycemic parameters in patients with new onset diabetes during COVID pandemic are more severe than in patients with new onset diabetes before the pandemic. This was called as a new onset diabetes COVID India study, and the glycemic parameters for those people who were detected during COVID, NOD COVID, they were, you can see here, the need of insulin was quite high. Oral antidiabetics, the number of antidiabetic drugs required was quite high. And there was, you can say, the glycemic parameters, or especially HbA1c, new onset diabetes prior to COVID pandemic, 9.2% HbA1c. And during COVID, if the diagnosis was diagnosis afresh, 10.1%. So bad glycemic parameters. And post-COVID syndrome or long COVID syndrome, different labels, but meaning is same. Professor Anup Mishra asked he has given some features of these. Type 1 is symptoms with varying lengths of recovery, rehabilitation. Type 2 is symptoms persisting for 6 weeks from the time of initial infection, and so on and so forth. So various types are there even in the post-COVID syndrome, and then different organ you can say systems are involved. So new onset diabetes, kidney dysfunction, lung symptoms, especially fibrosis and breathlessness, cardiac dysfunction, liver dysfunction, neuro dysfunction, sarcopenia, very, very important. And related to diabetes, more of diabetic ketoacidosis and psychiatric issues, so on and so forth. So post-corona or post-COVID syndrome, diabetes again is a collision. Understood biological factors are continued inflammation and altered immune reactions, pre-existing organ damage, newly inflicted organ damage, pre-existing because of diabetes and newly inflicted because of corona, unrecognized microthrombi and endothelial inflammation, persistent tissue reservoirs. This is something which is interesting. Persistent tissue reservoirs of SARS-CoV-coronavirus, altered brainstem and vagus responsiveness, autoimmunity due to mimicry between SARS-CoV-2 protein and other body proteins, reactivation of other viruses, and are some of the less understood mechanisms which could result in post-corona syndrome. In addition, post-critical illness effects, secondary bacterial fungal infections, stress, steroids, socioeconomic status may play important role. So post-COVID POTS is something which is an interesting entity seen quite frequently. Postural tachycardia syndrome, rise in the heart rate more than 30 minutes in adults, more than 40 minutes in adolescents, 10 minutes after assuming erect posture. And this was not accompanied by orthostatic hypotension, which is a feature of diabetic autonomic dysfunction. And this persisted for at least 3 months post-COVID. Long-standing diabetics may already have diabetic autonomic neuropathy and could have orthostatic hypotension. If both POTS and DAN, that is diabetic autonomic neuropathy, coexist, the patient can have worse problem. Post-COVID muscle weakness is something which is very important. After COVID illness, hospitalization, poor nutrition, protein deficiency, corticosteroid injections, patients may lose their muscle mass. Indian diabetics are already having sarcopenia, especially those who are elderly, especially elderly women, or poorly controlled, either type 1 or type 2 diabetes. So taken together, this sarcopenia can worsen post-COVID fatigue, may prolong the bedridden status of the patient and prolong the recovery. And lung fibrosis is also seen more often in uncontrolled diabetics and can prolong the recovery. Sarcopenia, of course, is something which is important for worse diabetes control, even in the post-COVID phases. Now, post-COVID microvascular diabetes complications, I have already alluded to that: capillary cell swelling, microthrombi, endothelial inflammation, retinal, especially the pericyte damage, scarring, all have been documented in diabetics with COVID. Acute kidney injury has been seen in COVID independent of diabetic status, and acute kidney injury was one of the important determinants of worse COVID outcomes, even in non-diabetic patients. Effect of COVID infection and its severity on microvascular diabetic complications is being actually documented, studied in huge worldwide registries. Like this is called as a COVID-DIAB registry. And this registry is actually initiated and being thoroughly studied and taken forward by my guru, Professor Paul Zimet from Baker's IDI, Melbourne. So let us again look back to the Minister of Health and Family Welfare suggestions. This is acute COVID signs, symptoms up to 4 weeks. Ongoing COVID symptoms, signs and symptoms from 4 to 12 weeks. This is ongoing symptomatic COVID. But something which is beyond 12 weeks of the initial infection is the post-COVID syndrome. And what are the do's and don'ts in this period? This is again something which is very important for all of us practitioners. There are some do's during the post-COVID period, and there are some don'ts which are in the post-COVID period. So frequent hand washing, restructure routines, greater emphasis on healthy weight, healthy eating habits, proper visits to the physicians, importance of hypertension, diabetes, dyslipidemia control, etc. These are the do's in the post-COVID period. Which are the don'ts? If the person has persistent symptoms like fatigue, breathlessness, fever, limit the activity to 60% of maximum heart rate, which is very important, until 2 to 3 weeks after the symptoms resolve. Intense cardiovascular exercise, don't undertake these for at least 3 months or unless you consult your physician. Don't stop medication of diabetes or maybe blood pressure, lipids, till you can say further instructions have been given by your consultant. And do not ignore the warning signs such as high grade fever, oxygen saturation less than 93%, chest pain, dizziness, syncope, or palpitation. Mind you, the COVID adversity is still not fully over. So these are the interactions between the capillary function, inflammation, hypoxia, transmission. So the person had COVID. However, he had some huge inflammatory disturbances, some huge immune disturbances, procoagulant state, hypercoagulable state, and naturally circumstantial because of the COVID lockdowns or COVID stress, disturbance in the routine, disturbance in the exercise, disturbance in the day-to-day eating patterns, lot of, you can say, outside food order, etc., etc. So exercise is not there. At least it was disturbed. Diet was disturbed. Stress was there. Some people found it difficult to procure the medicines and the glucometer strips regularly, especially in the lockdowns. So all this and the pathophysiology, especially at the capillary and the endothelial level, that certainly induced tissue hypoxia. As I have already told you, this was at the root of brain problems, heart problems, kidney problems, immune responses, the muscle problems, and even in the metabolic problems. So this is just an example of acute kidney injury, which can certainly result not only in chronic kidney disease, glomerular disease, but maybe even in the hypertension. And as I have told you, AKI is an independent predictor of mortality and poor outcomes in COVID-19 patients who had diabetes or who don't have diabetes. And these are the different severities clinically. No COVID, continue whatever diabetic drugs, metformin, sulfonylureas, gliptins, SGLT2 inhibitors, insulin, etc. Mild COVID in the primary care, continue metformin, gliptins, SGLT2 inhibitor, GLP-1 receptor agonist injection, insulin injection, sulfonylureas, alpha glucosidase inhibitors. But pioglitazone, be cautious. Moderate to, let's say, severe COVID, here you should be more cautious. Use gliptins without any problem. Insulin, of course, remained the drug of choice. But in the severe patients, generally, we didn't encourage the SGLT2 inhibitor use, metformin use, GLP-1 receptor agonist use by choice. And the other drugs, like for example, steroids or ACE inhibitors, ARBs, they were certainly observed to have some issues. Glucocorticoids, of course, they had anti-inflammatory properties. They were life-saving for some patients, but they certainly gave hyperglycemia. Of course, in non-diabetics, but even in non-diabetics. And this is our own guideline. This is from the Association of Physicians of India, published September 2021. And this was specifically pertaining to one very important instruction, confirmation of post-COVID syndrome. So post-COVID syndrome is something which is persistent beyond 12 weeks of the index corona infection and not explained by any other differential diagnosis. So in patients with diabetes or new onset hyperglycemia, mind you both, specific focus on blood glucose, stabilized glucose, priority on low risk of hypoglycemia. So use more of gliptins. Let's say in this stage, you can use SGLT2 inhibitors also. Lab tests to assess the pancreatic beta cell function, so C-peptide levels especially, and intense patient education and psychological support. In all patients, dietary advice, nutrition team to be, you can say, coming to the force, advice on the exercise and physical activity, physiotherapy and exercises for the patients who are sarcopenic or who are taking oxygen or who are having lung fibrosis, appropriate symptomatic supportive therapy, including pain relief, psychological support and counseling, and appropriate timely referral to the related specialist. So before now winding up my presentation, I will just show you some of the recent observations. These were 133 type 2 diabetic patients with mild asymptomatic COVID, 67 diabetic patients with COVID pneumonitis. Of course, their glycemic parameters were noted, and they were given the SGLT2 inhibitor and gliptin combination. And this is a study, this is published by Professor Shashank Joshi in May 2020 in Endocrine Practice. What was Joshi sir's observation? HbA1c came down from 8.6 baseline to 7.1 after 6 months of empagliflozin gliptin treatment. Fasting sugar came down appreciably by 57, postprandial came down by 67, and body mass index also came down by 2.6. So generally it was observed that patients of diabetes and COVID infection or even COVID pneumonitis, you can certainly keep on using metformin, and if the patients were not at control, you can certainly use a combination of gliptin and gliflozin to avoid hypoglycemia and to give you good glycemic improvement. Professor Kamlesh Kunti, Professor Melanie Davis from Leicester, UK, have also commented that our problems of diabetic control post-COVID are going to be higher. Number of newly diagnosed diabetics is going to be higher. The prevalence of complications is going to be higher. And that is why they have said that probably metformin and the GLP-1 receptor agonist, SGLT2 inhibitors, could be the drug of choice. This is a comment on the diabetic foot disease after COVID, so post-COVID. And these researchers have said that intense use of telemedicine and video infection of the diabetic foot, which is facilitated by the video consultation, that will be something which will be extremely useful, because diabetic foot patients are anyway finding it difficult to travel, to come regularly to the clinic. So video consultation certainly can be used in these situations. So video consultation is something which is very, very important contribution to diabetes care. And that was a blessing in disguise by the COVID pandemic itself. These are from the experts of National Health Scheme UK, and they have said that this is a time post-COVID when we can certainly focus more not only on complication management, but for prevention of type 2 diabetes, induction of type 2 diabetes remission by intense diet and exercise, effective treatment to prevent complications which are not already there, effective monitoring and treatment of complications, and self-care during the hospitalizations if at all required. So societal measures required to improve diet and lifestyle in most of the patients. So we should certainly encourage that. Induction of remission is something which is very intense patient education, making them adhere to a good diet, which is low calorie, wherever indicated, and try to prevent new onset diabetes, because a lot of post-COVID hyperglycemias may not turn out to be newly diagnosed diabetics. They might revert back from hyperglycemia to euglycemia. So we have to try that. Two new drug classes, as I have already alluded to, GLP-1 receptor agonist and SGLT2 inhibitors, for the first time reliably reducing weight and preventing heart attack, giving nephroprotection, could come as a drugs of choice in the patients of post-COVID diabetes. So very important as a system, the concept of one-stop shop that builds on the retinal screening done maybe in a peripheral center, the reports sent to the referral center through internet, through video photographs, and then similarly the food screening, weight monitoring, BP monitoring, using the telemedicine and the newer technologies from the remote corners of our country to the referral centers, to the experts, and then taking the presence or absence of complications and maybe a better and effective management through these kind of newer gadgets, something which is very, very important and relevant in the post-COVID phase. Not to neglect is the diet. And we have already, you can say, been going through all this in the post-COVID syndrome. We have impaired immune responses. So vitamin D, minerals, and immunostimulants are important. Inflammation, so omega-3 fatty acids, monounsaturated fatty acids, dietary fiber could probably be certainly included in the diet to recover from sarcopenia. Adequate energy intake, protein intake, and minerals are necessary, and to reduce oxidative stress, polyphenols, vitamin E, vitamin C, vitamin A, glutathione, carbohydrates with low glycemic indices, something which is certainly recommended. We can't ignore in the post-COVID phase mental health issues, and mental health issues could be applicable not only to the patients or persons who have suffered from COVID, diabetics who have suffered from COVID, but their family members, their friends, and let me tell you, even their neighbors, society at large. And we physicians also need to be actually taking the things in a more correct perspective to avoid stress in these trying times. And we certainly should be using more of telemedicine to handle the post-COVID complications of diabetes, so that neuropathy, retinopathy, nephropathy can be better documented, the severity can be better documented, referral to the proper specialist can be done in a correct and timely manner. And for this, Professor Anup Mishra, one of our senior guides from Delhi, he has already published at least 2-3 times that you should be using more of telemedicine for better diabetes care in the post-COVID era. Before you can say stopping my presentation, let me tell you something which is the latest again, and this has again come from the latest American College of Endocrinologists meeting which happened last week. They have commented on these causes of death in the US residents with diabetes in the last 3 months of 2020. So October, November, and December 2020. Let's say the lull between the first corona wave and the second corona wave. Look at the figures. This is 24.7% of deaths were attributable to COVID-19. 24% of the deaths were attributable to coronary cardiovascular disease, and 24.1% of the deaths were attributable to diabetes. So at least during those 3 months, it was corona who had overtaken the established enemies of cardiovascular disease and diabetes. This is something which is the latest. So I believe that we have to take cognizance if we want to handle the diabetics known and having got corona infection and now in the post-COVID phase. Their complications should be done as an assessment right when they come across as a patient to you, and let us document the complications. Let us take multi-specialist team help and address those complications more effectively as far as the standard of care is concerned. This is the, you can say, most important publication from Devi Sridhar. The book is called as Preventable, and the detail is how a pandemic, this corona, changed the world and how to stop the next one. So Sridhar's central message is well work. COVID-19 put into the stark relief how global politics shapes our health. No pandemic response is likely to be equable and fair unless the society is. My friends, I believe that we have gone through a pandemic. Let us not be carefree or careless. Let us be aware of the diabetes patients who are already, you can say, having more problematic for infections. Corona has really shaken them. More complications, where likely more complications are being seen. So let us be vigilant. Let us, you can say, handle these complications in a more scientific and vigilant and careful manner. I thank you so much for your patient listening, my friends. Thank you so much.
Thank you, sir, for such an excellent and in-depth, especially very immersive presentation, sir. I'd like to request my dear audience to please put up their questions in the provided link or the chat box, and our honorable speaker is ready to take up questions. So before we move on to the questions from the audience, especially, so I'd like to know that what percentage of patients do you see with diabetes post-COVID?
Okay. Now, as far as my own observations are concerned, I will answer this thing from two desks. One is my private setup, that is the, let's say, paid consulting practice. And there is another desk where I am the physician for Pune Municipal Corporation. So it's a free OPD. So two different kinds of scenarios. The percentage of people who have suffered from COVID and now getting diagnosed newly is certainly very high, but that is higher in the low socioeconomic strata. Because I believe that probably the vigilance and everything, if it was not, you can say, proper prior to COVID, now because of COVID, the person has got sensitized. He has got more, let's say, his family has become more concerned about the health, and they are probably more, let's say, attentive to the doctor's advice. So the documentation and the investigations are increased because of the suffering of corona. So in a low socioeconomic strata, that is the observation. In the higher socioeconomic strata, more educated people or the paid kind of practice, in that practice also I am seeing that especially the younger lot, okay, especially the younger lot, their lifestyles, their work from homes and food orders from outside and their inability to visit their gymnasium, lot of these factors and quite a few of stress, because they had to look after their parents who probably suffered from COVID, or their already existing diabetes, hypertension, heart conditions, arthritis, etc. Procuring of medicine, taking care of them, if at all required, taking them to the hospital for admission. That was certainly a challenge on the working generation. So those in the 30s and 40s found it really stressful to cope up with these things, and they got diabetes newly. That is an observation in the private practice. So the overall point, if you really ask me, it's very difficult to comment on the percentages, but there have been some other observations also. Those who are sensible, health aware, and immediately started looking after their sugars without any symptoms, and they had diabetes because they had suffered from corona. So their glycemias are going to euglycemia sooner than later, a period of anywhere between 6 weeks, 12 weeks, maybe 6 months or so. Those who have really been, you can say, not that much attentive or health aware, they got detected post-corona or post-COVID, but their A1Cs were already 11, 12. They were already, you can say, started on insulin. And they were probably in the ICUs, they were on steroids for a long time. They were on ventilators also sometimes. So there probably beta cell damage is more. In quite a few of them, I would certainly tell you more than 50 odd people of this kind who had certainly done that beta cell function assessment in the form of C-peptide levels. And at least 20% of them had a very poor C-peptide. And all these are adults. Okay. So the severity of corona is certainly casting its shadow on the post-COVID scenario. No question about it. And those who were not a good control, non-diabetics, not a good control prior to COVID, got COVID somehow or the other, maybe in 2020, maybe in 2021, some were actually not requiring hospitalization also. They were completely, you can say, quarantined and they got all right. Some were hospitalized, but they were in the wards. They were not in the ICUs. So depending on the pedestal on which they were, non-diabetic, corona, mild, moderate, or maybe severe corona. So those who had severe corona, their organ damage prevalence is very high, especially that kidney damage, albuminuria, because the definition of CKD is that albuminuria. So everybody has not dropped the eGFR, but microalbuminuria certainly is a problem for quite a few of these people. That's what is my observation. Even some people have gone down on their left ventricular ejection fractions also.
Thank you, doctor. So as you see that there are a lot of complications, especially with the renal, with the opthal complications in these patients. Doctor, do you suggest that individuals who have developed diabetes post-COVID, they require a team of specialists for the management, or a diabetologist or an endocrinologist is sufficient enough to treat these patients?
Yeah. One particular study, NOD India, I have shown, or NOD COVID India, I have shown. And I have shown there that at least as far as our patients are concerned, Indian patients are concerned, those who got diagnosed during COVID, COVID made them undergo investigations, they got diagnosed, etc. So their glycemic parameters were far worse than those who otherwise got detected, that is pre-COVID detection of new onset diabetes. Professor Mohan had actually also commented on that, and he has also said that yes, the COVID new onset diabetes patients are someone where the metabolic state is not, you can say, optimum. So they need a continued surveillance. They need a continued intensive patient education. Something very important. Quite a few of them are devoid of any complications. Their diabetes is not long-standing. It's recently diagnosed. So they don't, you can say, they may be spared of the complications, but their glycemic status is not good. And if they were in the ICU on ventilator support, were intubated, etc., then, as I told you, their likelihood of that continued albuminuria is there. Their likelihood of peripheral neuropathy symptoms is certainly there. And they require a very vigilant kind of a monitoring, rigorous glycemic control. And otherwise, you can say even the blood pressure and lipids, everything needs to be there. So certainly they should be cared for by specialists.
Thank you, sir. Thank you for this insight. But now we move on to a series of questions that we have received from our audience. Since it's a pan India, so we have a mammoth of questions, Pratak, and some of them have already been covered by you. So we move on to the first interesting question. Is that this is Dr. Wali from New Delhi would like to know that is there a role of a high protein diet and supplements in management of diabetes?
Yeah. Uh, my last few slides I have already shown, and there is a comment from Professor Anup Mishra from Delhi that the casualty in the COVID periods is the dietary discipline. And I fully agree with him because COVID naturally took precedence over any other health issues during the pandemic. So people were certainly suffering from different kinds of situational and maybe medical problems. So diet was definitely a casualty or it was neglected. The important point here is high protein diet specifically recommended to build up muscles, that sarcopenia thing. Those people who are relevantly, you can say, affected there. Now, to build immunity, again, I will repeat here that there is nothing like, you can say, an RCT, a randomized controlled trial, to show us that this is the low vitamin D level, this is, let's say, supplement of vitamin D given, now the levels have improved, and maybe now the inflammatory substances, the interleukins and all those, the levels have gone down. There is nothing like a RCT here. But a few small studies certainly support this kind of argument that, well, yes, to build immunity, you certainly require vitamin D, vitamin C, the riboflavins. So generally multivitamin, I would say, vitamin E also is mentioned. So that is one aspect. High protein diet certainly coupled with good physical exercise, preferably under a good guidance. So if that is done, certainly the person can expect to build the muscle mass. And muscle, as we understand, is one of the biggest customers of blood glucose. So you have a better build of muscles, you have better number of insulin receptors on the skeletal muscle cell membranes, which are actually recruited and increased because of physical exercise. So you have better sites of insulin receptors who are insulin sensitive or insulin obeying. So that way, you can certainly expect a good control of diabetes by, but this is not only protein supplement, into bracket is a good physical exercise as well.
So, doctor, do you suggest any nutritional change for these patients?
Can you repeat, please?
Do you suggest any nutritional change in these patients?
Oh, yeah. Nutrition. In fact, I have seen already, and I have during my discourse, I have already commented on that the people during the pandemic, some bad habits also certainly have been, you can say, there. And one of that is not moving out of the house because you are not compelled to do that. You are working from home. And certainly the exercise was a casualty. Diet, well, now diet should not be a casualty because now the markets are open, etc. in the post-COVID. But the habits don't, you can say, leave you very easily. So ordering food from outside is something which is still a sustained kind of a habit. So any food which is of order category or maybe out of home food, for health generally it is not very good. So it could contain higher amount of oil, it could contain repeatedly boiled oils, then which are saturated or oversaturated. It could contain higher amount of salts and maybe even higher amount of glucose. So these are not really, you can say, ideal for the health, especially metabolic health. The use of very finely ground wheat, which is called as maida, is also very high in these kinds of foods. So that is something which we can certainly instruct the patients to avoid and go back to the home cooking methods so that these adversities can be certainly avoided.
Thank you, doctor. So the next question is from Karnataka. Dr. Sunita would like to know that is there any arthritis-related complications in post-COVID?
Okay, very well. This is something which has been observed certainly, but again, I tell you that these are observations, and lot of that observation is because probably the muscle mass has gone down. Okay, sarcopenia is something which is certainly there, especially for people who were in the hospital, in the ICUs, maybe on ventilators, and now have come out, maybe elderly, maybe having a long time ailment like diabetes, hypertension, etc. They certainly have lost muscle mass. Therein, the load on the bones and joints has certainly gone up. Two, it is very important to, let's say, bring to the whole attention of our doctor friends that common thread between COVID and diabetes is none other than inflammation. COVID is acute inflammation, acute thrombotic stage. Diabetes is protracted or chronic inflammation, protracted prothrombotic state. So if somebody is already diabetic and now undergone an attack of COVID, so to say, then that inflammatory attack or inflammatory damage, which is going to be inflicted, certainly can damage the musculoskeletal system. So, well, yes, arthritis certainly is there. Arthritis certainly is worsened because of bedridden patients. And maybe I would say, this is a circumstantial conjecture. People were not able to venture outside. People were banned from venturing outside. And post-COVID, quite a few elderly citizens are afraid of venturing outside. So all these can certainly culminate into joint problems. No doubt about that.
Thank you, Doctor. So the next two questions from Tamil Nadu and Maharashtra is from diabetic foot. And here the Dr. Dinesh would like to know that what is the management? Is there any change in the management of diabetic foot ulcer treatment post-COVID? And Dr. Manoj from Maharashtra would like to know about burning feet syndrome.
Yeah, I will deal with that DFU first. So because of some amount of, you can say, commonality between the previous understandings of diabetic complications, diabetic foot, diabetic neuropathy, diabetic eye or retinopathy or diabetic kidney disease, the tenets of advices and standards of care have not changed. Okay, they are same. That is document, and if they follow, document, and if they are there, then do a rigorous ABC control, HbA1c, blood pressure, cholesterol. Ask the patient to do a good physical exercise, balanced diet, and maybe trying to give him a good sleep also, and the sleep in night hours, not in the day or other hours. So all these two, you can say, maintain the circadian rhythms also. So the new instructions post-COVID are the monitoring needs to be intense. People all over the world were blissfully unaware of their complications. So nobody has a symptom of albuminuria. Nobody has a symptom of insensate food. That's what the definition of insensate food is. So let us actually try to see to it, though the patient is maybe a newly diagnosed diabetes, or though the patient may be 10-year-old duration of diabetes, let us actually do the Semis-Winston monofilament test. Let us do the 128 millihertz tuning fork test. Let us do that seriously. Let us look at his albuminuria. Let us look at his EGFR. Let us have a fundus. Let us have a fundus examined by ophthalmologist. So let us document first, and then the help from the telemedicine is something which could prove to be vital. Okay. So we, in my setup, what we have been doing, especially post-COVID, is we are arranging camps, or maybe we are calling the patient in groups for especially fundus photographs, which can be managed that way. And those fundus photographs I am sending to the University of Ontario, and 4, you can say, retina specialists. They are commenting on that, and they are sending the mail along with the photographs within 24 hours. So I can take these reports to the patients, and I can certainly be more vigilant about presence or absence, or maybe continued care of diabetic retinopathy. Those with diabetic retinopathy, diabetic nephropathy is something which is a matter of, let's say, sorting out right then and there. Somebody now insensate food, intensively advise them to use those protective diabetic footwear. Very important. 2, ask them to actually be in your touch, maybe on a video consultation, at least once in 15 days, at least once in a month, so that you can see their sole of the foot. This is, I will repeat here, there is no substitute for a good bedside clinical examination, but at least rather than nothing, you can use a video consultation, you can use that telemedicine aspect, and you can keep a good vigil on the diabetic foot, instruct them properly, and maybe call them to your clinic from time to time. If you feel that maybe there is a blister, there is a sore, there is a callus which you need to tackle, or maybe intertrigo, whatever.
Thank you, Doctor. So moving on to the next last two questions, probably. Here, the doctor would like to know that in case of post-COVID, if some individual develops diabetes, especially as young as 44 years, and they are on metformin, and PP is not in control. So, what can be done? And also, we like to know whether it is self-limiting, whether it after uh, treatment of like 6 to 8 months,
Okay.
do you see a decline in diabetes?
Yeah. I have already shared my experience. If the post-COVID diabetes is detected sans any symptoms, without any symptoms, because of the patient's health awareness, then probably these are the ones who are more likely to respond, and their diabetes can wean out. The hyperglycemia can wean out. They can regain euglycemia. They can continue to be off drugs also. But it's a question of time, and that timeline is something which is very difficult to really pinpoint and define. So if somebody is already on metformin, the postprandial is not getting controlled. If the person is obese, overweight, you can certainly think of giving a SGLT2 inhibitor. You can certainly think of giving maybe even metformin, sulfonylurea, metformin, gliflozin, and a gliptin also. Why? Because they are not likely to give you hypoglycemia. And SGLT2 inhibitor is likely to give a good visceral mass reduction, abdominal or waist circumference reduction, and SGLT2 inhibitors also have nephroprotective effect. In these runs, nephroprotection is something which is important, that albuminuria can be certainly addressed. Very important. And there is nothing like, you can say, a separate instruction for post-COVID diabetics on maybe any drug now, any drug. You can use the standard anti-diabetic drugs, just like you were using pre-COVID now. There is no problem. But important is that urgency of control is something which needs to be reiterated.
Thank you, Doctor. So moving on to the next question, very interesting question from Dr. Anil from Maharashtra. He would like to know what antiplatelet agent should we prefer to avoid microemboli?
Yeah. With the availability of the drugs like rivaroxaban, which were recommended for those people who had been in the hospital for a prolonged period of time, were obese, maybe senior citizens, accompanied by comorbid like hypertension or maybe ischemic heart disease, those who had a poor LVEF, etc. Or those who were more likely to be, you can say, restricted activities even after discharge from COVID. They were the ones who were really put on drugs like rivaroxaban, we know, and they were continued on that drug. For some hospitals or some protocols put them on these for 3 months, some put them on these for 6 months. So not only antiplatelet, but maybe the anticoagulants type, new oral anticoagulant, non-vitamin K, etc. So that was one aspect of the story. That is something which was specifically for those microthrombi, right? And as far as our traditional antiplatelet drugs are concerned, if required for a diabetic along with hypertension or maybe other comorbs, naturally antiplatelet drugs need to be given, and then need to be given continued for a lifetime.
Thank you, Doctor. So do you often see any weight loss also post-COVID in diabetic patients?
Yes. Part of the weight loss is sarcopenia. Part of the weight loss is because of the, you can say, affection. Lot of people had GI affections. So vomiting, diarrhea, and many other things. And maybe even the other infections, apart from COVID, other infections. So these were the people who, and of course the LFTs were deranged in quite a few of COVID cases. We know that. So these were the people who certainly were, you can say, even after discharge, they continued to have, you can say, poor appetite and muscle mass loss because of infection, hospitalization, steroids, and of course the post-COVID, in the post-COVID state also stress. So appetites being poor and the overall stress level being high, the patients or the family's attention to a, let's say, nutritious diet could probably take a backseat. So that is one of the important contributors to post-COVID weight loss or maybe post-COVID muscle mass loss. So we certainly have addressed that issue in our discussion, and we need to really pay attention.
Thank you, Doctor. So this was probably the last question which we could take, and due to constraint of time, may I request for your take-home message, Doctor, for your audience?
Yep. And I believe the first slide which I have shown, COVID and diabetes, two different storms, two different pandemics. COVID raging over the last 2 years, but diabetes raging over the last few decades. And when they collide, certainly go into what is called as a collusion. So their ways of attacking and damaging the body systems are fairly common through inflammation, through prothrombotic states, and multi-organ dysfunction. That is something which is common to them. So now, once bitten, twice shy. We have seen that COVID is dangerous. We have seen that it can really kill people and kill people in masses. So from that point of view, we need to be really serious about the vaccination programs, completing the whole 3 vaccines for most of the Indians. That's something which I can certainly be very, you can say, aggressive on. And lifestyle, looking after health, looking after physical exercise, proper nutrition. If there is an element, monitoring and timely visits to your doctor, that is the way which certainly keep ourselves not only healthy, but our future generations also need to be healthy. The adolescents and the young who were very, very, you can say, heavily affected, as I have already shared. This is our next generation. So diabetes, if at all, and the other metabolic problems, cardiovascular problems in this generation, if we want to avoid, let's take that COVID as an opportunity to be more vigilant and attentive as far as our physical body, our physical health is concerned, our psychological health is concerned, and the health of the family and the society at large is concerned. So let's be vigilant. Let COVID, you can say, not come in any different form. That is something which I pray. And the doctor community is something which certainly can be a flag bearer for future health of our country and the world. Thank you so much.
Absolutely agree with you, sir. Thank you so much for your valuable time, and also like to thank you for your food for thought take-home message for all the dear audience. So on behalf of Sun Pharma, I like to thank you, Dr. Suhas, for the in-depth presentation and updating us with the vast knowledge. It was a pleasure and an honor to have you with us this evening, sir. I also
thank you, doctor. Thank you so much.
I also like to
everybody who participated, and thanks for the questions. Thank you.
Yes, sir. It was really, I like to thank our audience for their thought-provoking questions. As we sign off, I like to thank everyone for their participation and making this platform a good success. Thank you once again for your kind support, and we look forward to meet you once again in another enriching academic endeavor from Sun Pharma. Wish you all a pleasant evening. Thank you.
Thank you.